We have all done it. Walked into a room and forgotten why we went there. Stood in the kitchen with a name on the tip of our tongue that simply would not come. Looked for glasses that were sitting on top of our head. And told ourselves, with a mixture of mild amusement and mild unease, that this is just what getting older feels like. For most of those moments, that explanation is correct. The occasional word-finding difficulty, the misplaced keys, the momentary blank on a familiar name, these are features of normal cognitive aging that affect virtually every adult and that do not represent disease, do not predict decline, and do not warrant medical investigation. But there is a different category of memory and cognitive change, a category that is not the ordinary forgetfulness of a busy mind or an aging one, a category that looks similar enough to normal aging that it is consistently dismissed by the people experiencing it and by the physicians they mention it to, but that is in fact clinically distinct, prognostically significant, and in many cases associated with underlying processes that are diagnosable, treatable, and in some cases reversible. 6 signs separate this category from normal aging. 6 specific patterns in how memory and cognition are changing that tell a different and more urgent story than the ordinary forgetting of everyday life. And most adults over 60 who are experiencing them have never been given the vocabulary to distinguish what they are going through from what everyone around them seems to be going through as well. My name is Dr. Favor Clinton. I have over 10 years of clinical experience, and cognitive health in older adults is one of the areas I believe receives the least nuanced attention in primary care. The line between normal aging and early pathological change is one that matters enormously for the people on either side of it, and it is a line that this video is going to draw as clearly as I possibly can. Stay with me through all 6 signs, because this is not a video designed to frighten you about normal forgetting. It is a video designed to help you recognize the specific patterns that deserve more than reassurance. Before we go through the 6 signs, I want to give you a clear framework for distinguishing normal cognitive aging from the patterns that warrant investigation. This framework is the one I use in clinical practice, and it is the one that most reliably separates the patients who need reassurance from the patients who need evaluation. Normal cognitive aging involves changes in processing speed and in the efficiency of memory retrieval. Older brains are not less capable. They are differently capable. They hold more accumulated knowledge, more contextual understanding, and more nuanced judgment than younger brains. What they do less efficiently is retrieve specific items of information quickly on demand, particularly in situations of divided attention or time pressure. The key features of normal cognitive aging are these. The information is there. Given time, context, or a cue, the forgotten name comes. The misplaced keys are found in a logical place. The word that was on the tip of the tongue arrives during a later conversation. The memory works, just more slowly and with more effort than it did at 40. Pathological cognitive change has different features. The information is not just slow to arrive. In many cases, it does not arrive at all, even with cues and context and time. The memory of an event is not just difficult to access. The event itself is absent from memory entirely, as though it did not happen. The language difficulty is not just word finding. It extends to sentence construction, to following complex instructions, to losing the thread of a conversation that should be entirely comprehensible. The second distinguishing feature is progression. Normal cognitive aging is stable. The occasional forgetfulness of a 65-year-old looks similar to the occasional forgetfulness of that same person at 70 and at 75. Pathological change progresses. It is measurably different at 12 months than at 6 months. The person themselves notices the change. The people around them notice the change. The change is not a stable feature. It is a direction. With that framework in mind, here are the 6 signs that fall on the pathological side of the line. I want to tell you about a patient I will call Rosalind. Rosalind was 68 years old when her husband accompanied her to an appointment with me, something he had never done in 30 years of her medical care. He came because he was worried in a way he could not fully articulate. He said she seemed different. Not dramatically different, not in a way that strangers would notice, but different enough that he lay awake thinking about it. Rosalind herself was not worried. She acknowledged that her memory was not quite what it had been, but she attributed it entirely to the stress of the previous 2 years, which had included her mother's illness and death, her own retirement from a demanding hospital nursing career, and what she described as the significant cognitive adjustment of no longer having the daily structure that work had provided. All of those explanations were plausible. All of them could genuinely contribute to cognitive changes in an older adult. The question was whether they were sufficient to explain what her husband was observing, or whether something else was also present. When I spent 40 minutes taking a careful cognitive history from both Rosalind and her husband separately, and when I administered a comprehensive cognitive screening battery, the pattern that emerged was not the pattern of stress-related cognitive fatigue. It was the pattern of mild cognitive impairment, a specific clinical entity that sits between normal aging and dementia on the cognitive continuum, and that carries a meaningful probability of progression to dementia over the following years if the underlying drivers are not addressed. Rosalind had 4 of the 6 signs I am about to describe. None of them had triggered a formal cognitive assessment in the 2 years during which they had been present, because each one, taken individually and described casually to a busy GP in a standard appointment, had been attributed to stress, retirement adjustment, or grief. Nobody had asked about all 6 together. Nobody had administered a formal cognitive assessment. Nobody had investigated the underlying drivers that were accelerating her cognitive trajectory. We did all of those things. What we found was a combination of undertreated hypertension, sleep-disordered breathing that had never been diagnosed, and vitamin B12 deficiency, all of which are known and treatable contributors to cognitive decline. Addressing all 3 did not reverse Rosalind's mild cognitive impairment, but it measurably slowed its progression, and in her husband's words, brought her back in a way that had not seemed possible 6 months earlier. The distinction I want to draw here is specific and important. Normal aging involves difficulty with details. You remember having the conversation but cannot recall the exact words. You remember attending the event but cannot recall who else was there. You remember making the appointment but are not certain of the exact time. The sign that warrants concern is forgetting the event itself, not the details of the conversation, the fact that the conversation happened, not the time of the appointment, the fact that the appointment was made. Not who was at the gathering, the fact that the gathering occurred. This type of memory failure, called episodic memory impairment, reflects a specific failure in the brain's ability to encode new memories, not just retrieve old ones. The hippocampus, the brain structure most critical for forming new episodic memories, is among the first areas affected by the pathological processes of Alzheimer's disease and vascular dementia. When the hippocampus is compromised, events that should be consolidated into long-term memory are not stored effectively. They are not just hard to retrieve, they were never properly recorded. The practical indicator is whether the forgotten event can be retrieved with a cue or a reminder. If you tell me that you had dinner with a friend last Tuesday and I have no memory of that conversation at all, even when you describe it in detail, even when you remind me of specific aspects of it, that complete absence of the memory despite cueing is qualitatively different from normal forgetting and represents a pattern worth formal assessment. Ask yourself honestly, are the things you are forgetting details of events you do remember, or are they entire events that have left no trace? Spatial disorientation in new or unfamiliar environments is common at any age and is not a sign of cognitive pathology. Getting confused navigating a new city, having difficulty finding your way in a hospital or an airport, requiring more time than you used to when driving a new route, none of these are concerning. Getting lost or confused in places that are thoroughly familiar is different. Becoming uncertain of your route home from a shop you have visited weekly for years. Feeling briefly disoriented in your own neighborhood during a walk you have taken hundreds of times. Needing to think consciously about which direction to turn in your own house to find a room you use every day. Spatial navigation depends heavily on the entorhinal cortex and hippocampus, areas of the brain that are among the earliest to be affected by the pathological changes of Alzheimer's disease. Research using advanced brain imaging has shown that spatial navigation deficits can be measurable years before a formal dementia diagnosis, because the neural systems that support navigation are among the most sensitive early indicators of hippocampal and entorhinal pathology. If you have experienced episodes of spatial disorientation in familiar environments, even briefly, even occasionally, and particularly if those episodes are becoming more frequent rather than remaining stable, this is a sign worth raising with your doctor specifically and asking for a formal cognitive assessment. This is Rosalind's first and most distressing sign. She had been a senior nurse for 35 years. She had managed complex clinical environments, coordinated care for multiple patients simultaneously, and navigated the intricate interpersonal dynamics of a large hospital ward with professional ease. In the 2 years before she came to see me, she had found herself increasingly unable to follow the plot of television programs she would previously have watched without effort. She had started avoiding dinner parties because she found it difficult to follow multiple simultaneous conversations. She had declined an invitation to join a book club because the prospect of reading and discussing a novel felt overwhelming in a way it never previously had. The cognitive processes involved in following a complex conversation, tracking a multi-threaded plot, or managing the demands of a cognitively engaging social environment are among those most sensitive to early pathological change. They require working memory, the ability to hold multiple pieces of information in mind simultaneously while processing them. They require processing speed, which declines more steeply in pathological cognitive change than in normal aging. And they require executive function, the ability to organize, prioritize, and shift attention, which is impaired early in most forms of dementia. The sign is not difficulty with things that were always difficult. It is difficulty with things that were previously easy. Rosalind had not found multi-threaded conversations difficult at 55 or 60. She found them difficult at 66 and 67. That change, from a stable baseline of competence to a progressive loss of that competence, is the pattern that distinguishes pathological change from normal aging. This is one of the signs that family members typically notice before the person experiencing it does, and it is one that is most consistently dismissed as a trivial quirk rather than a clinical signal. Asking the same question twice in a single conversation is not normal aging. Telling the same story to the same person in the same sitting without apparent awareness of having told it moments before is not normal aging. Returning to the same topic repeatedly within a short interaction as though each mention is the first is not normal aging. These repetitions occur because the episode of asking the question or telling the story is not being consolidated into short-term memory. The conversation has happened, but the brain has not recorded that it happened. The next question or story therefore arrives without the context of the previous one, because that context was never stored. The specific pattern to watch for is repetition within a single sitting, or within a period of an hour or two, rather than repetition across days or weeks. Everyone retells old stories over days or weeks. Retelling a story within the same conversation, or asking whether dinner is ready 10 minutes after having already asked and received an answer, reflects a specific short-term memory consolidation failure that is distinct from normal repetition. If people close to you have gently or not so gently pointed out that you have asked the same question or told the same story recently within a short time frame, please take that observation seriously. The people who live with us are often better positioned to observe this pattern than we are ourselves, precisely because we are not aware of the repetition when it occurs. This sign is perhaps the most frequently missed because it is the most likely to be attributed to entirely separate causes: depression, grief, life adjustment, stress, medication side effects. All of these can produce changes in personality, mood, and social behavior in older adults, and all of them are worth investigating as causes. But they are not the only causes. And in some people, particularly in the early stages of frontotemporal dementia, personality and behavioral changes are the primary presenting feature, occurring years before any significant memory impairment. The changes I am describing are not the sadness or withdrawal of reactive depression, though those can coexist. They are changes in the fundamental character of the person. A person who was warm and socially engaged becoming uncharacteristically withdrawn and uninterested in relationships they previously valued. A person who was patient and emotionally regulated becoming irritable, impulsive, or disinhibited in ways that are out of character. A person who was careful and conscientious about their responsibilities, becoming apathetic about things they previously cared deeply about. The frontal lobes, which govern personality, social behavior, impulse control, and motivation, are the primary areas affected in frontotemporal dementia, a form of dementia that tends to affect people at a younger age than Alzheimer's, and that presents almost exclusively with behavioral and personality changes in its early stages. A person whose personality has changed significantly and persistently, in ways that others close to them recognize as uncharacteristic, and for which no psychiatric or life event explanation is fully adequate, deserves a neurological assessment that specifically considers the frontal lobes. This is the sign that most consistently indicates that cognitive change has crossed from the domain of mild inconvenience into the domain of functional impairment. And functional impairment, defined as the inability to perform activities of daily living that were previously managed without difficulty, is the threshold at which mild cognitive impairment transitions into dementia by clinical definition. The tasks I am describing are not exotic or complex. They are the administrative and practical routines that have been manageable for decades. Managing a bank account or household finances, following a recipe that has been made many times before, organizing and taking medications correctly, managing a diary and keeping appointments, navigating the process of booking a medical appointment or renewing a prescription. When these tasks, which were previously automatic and unremarkable, become genuinely difficult or impossible to perform reliably, the cognitive change has reached a level that requires urgent, formal assessment, not watchful waiting, not attribution to stress or aging, urgent, formal assessment. Because the window in which intervention can most meaningfully slow the underlying processes is not indefinitely open. Rosalind's husband had noticed that she had missed 2 medication doses in the past month because she could not remember whether she had taken them. He had noticed that she had left the stove on 3 occasions when she had always been meticulous about kitchen safety. He had not mentioned these things to her GP because he did not want to embarrass her and was not certain they were significant. They were significant. They were the functional impairment sign that made the entire picture clinically urgent rather than clinically watchful. If you are experiencing difficulty with tasks that were previously routine, or if someone close to you has noticed this in you, please make a medical appointment this week and describe the functional changes specifically, not generally, specifically, with examples. The level of functional detail you provide determines how urgently the physician responds. I want to close this section with something I consider among the most important pieces of information in this entire video. Not all non-normal cognitive change is irreversible neurodegeneration. A significant proportion of cognitive decline in older adults is driven by conditions that are entirely treatable and in which addressing the underlying condition produces meaningful cognitive improvement. Vitamin B12 deficiency is one of the most common and most consistently missed causes of cognitive decline in older adults. B12 is essential for neurological function. Its deficiency produces a specific pattern of cognitive and neurological symptoms that can closely mimic early dementia, but that responds dramatically to B12 supplementation or injection when caught at an early stage. B12 deficiency is common in older adults for several reasons, including reduced gastric acid production that impairs absorption, vegetarian or vegan diets, and prolonged use of metformin for diabetes management. A single blood test identifies it. Hypothyroidism is a second commonly missed treatable cause. An underactive thyroid slows virtually every metabolic process in the body, including the brain. Cognitive slowing, memory impairment, and depressive features that appear to be dementia can in some cases be entirely explained by undiagnosed hypothyroidism and resolved by thyroid hormone replacement. A standard blood test identifies it. Sleep-disordered breathing, including obstructive sleep apnea, is the third. As we have discussed in previous videos, apnea events produce repeated overnight hypoxia that directly damages brain tissue and impairs glymphatic clearance. Undiagnosed and untreated sleep apnea is one of the most consistently documented and most consistently undertreated drivers of cognitive decline in older adults. It is diagnosed by a sleep study and treated effectively with CPAP therapy. Depression itself, when it presents primarily as cognitive symptoms in older adults, a presentation called pseudodementia, can be indistinguishable from early dementia on casual assessment and responds to antidepressant treatment in ways that neurodegeneration does not. This is the reason that formal cognitive assessment matters, not to confirm a dementia diagnosis that cannot be changed, but to identify whether the cognitive change is driven by something treatable before the window for effective treatment closes. I want to hear from you in the comments. Which of these 6 signs have you noticed in yourself or in someone close to you? And what was the response when it was mentioned to a doctor? Was it taken seriously, or was it attributed to normal aging and left at that? Your honest account in the comments helps me understand how consistently this distinction is being made in clinical practice. And your experience may be exactly what motivates another viewer to push harder for a proper assessment. If this video has given you the vocabulary to distinguish what you or someone you love is experiencing from what is simply getting older, please share it. Share it with the adult children of parents who are showing these signs and who have been told not to worry. Share it with the spouses who are quietly observing changes and do not know whether to take them seriously. The information in this video is the information that converts worry into action and action into outcomes that matter. Subscribe for more honest, research-grounded conversations about protecting your brain and your health after 60. Next time, we are going to talk about 8 silent signs your blood sugar is too high, even if your doctor says you are fine. That conversation connects directly to everything we have discussed about brain health, kidney health, and cardiovascular health, because blood glucose management sits at the intersection of all 3.